Hello. First, I would like to thank the editors of GIE for accepting our paper. Second, I would like to thank everyone who is watching this video accompaniment of our paper. I am presenting a manuscript entitled Outcomes of Upper Endoscopy Screening in Lynch Syndrome, a meta-analysis. This was a combined effort from authors from the University of Miami and University of Pennsylvania. Lynch syndrome is one of the most common hereditary cancer predisposition syndromes. It is caused by germline mutations in DNA mismatch repair genes with Lynch syndrome-related tumors typically carrying the hallmark finding of microsatellite instability. Lynch syndrome predisposes to a lifetime cancer risk of over 50% for colorectal and endometrial cancer. Therefore, there are robust recommendations for colorectal and endometrial cancer to reduce mortality. Lynch syndrome also predisposes to other cancers, including gastric and duodenal cancers, up to 9 and 11% respectively. In line with this, numerous societies and guidelines have considered a role of screening for upper GI cancers, but these recommendations vary significantly and lack consensus on whether, when, and how to screen persons with Lynch syndrome. Recently, there are several studies investigating the role of upper endoscopy screening for upper GI cancers. However, these studies are small and do not provide a clear consensus to guide screening practice. To clarify questions regarding the efficacy of Lynch syndrome-associated upper GI cancer screening in persons with Lynch syndrome, we performed a meta-analysis. Our primary outcome was cancers detected through the screening programs, not for symptomatic investigation. We excluded cancers diagnosed on endoscopy done for investigation of symptoms when reported as such. Secondary outcomes included other findings discovered during endoscopy visualization, such as Barrett's esophagus, gastric polyps, Helicobacter pylori, infection, and adenomas. Eligible studies were randomized controlled trials, cross-sectional, or cohort studies that used upper endoscopy as part of a screening program in persons with Lynch syndrome on asymptomatic patients without a known gastric or duodenal cancer diagnosis, and reported outcomes and findings discovered during endoscopy. Studies with multiple or similar authors were evaluated for overlapping populations to maintain independence of observations, and unanimous agreement amongst all authors identified the most applicable, inclusive source to include in this meta-analysis. As pathogenic EpCAM variants alter MSH2 gene transcription, data for EpCAM were included for MSH2 carriers. An estimate of the total number of endoscopies done during the screening period was calculated to estimate an event rate for each of the following. 1. Any upper GI cancers including esophageal, gastric, and duodenal, although esophageal cancers are not typically considered Lynch syndrome-associated cancers. 2. High-risk lesions including any upper GI cancer, plus additional findings of esophageal adenoma and Barrett's esophagus, gastric metaplasia, dysplasia, adenoma, or duodenal dysplasia, duodenal or ampullary adenomas, and atrophic gastritis was not included. And 3. Clinically actionable findings, the aforementioned cancers and high-risk lesions, plus H. pylori positivity. Total number of performed endoscopies was calculated to surmise utility of endoscopy screening. In studies that did not report the total number of endoscopies, the lowest possible number was used. Our meta-analysis identified 9 studies with 2,356 Lynch syndrome patients undergoing approximately 7,838 endoscopies. 47 Lynch syndrome-associated upper GI cancers, 18 gastric and 29 duodenal, 237 high-risk lesions, and 335 clinically actionable findings were identified. The pooled event rate for detection of any upper GI cancer, high-risk lesion, or any clinically actionable findings during screening were 0.9%, 4.2%, and 6.2% respectively. These rates correspond to a number needed to screen of 111.1 endoscopies for detection of one upper GI cancer, 23.8 endoscopies for detection of a high-risk lesion, and 16.1 endoscopies for detection of a clinically actionable finding. Notably, these calculations include the additional cancers not classically associated with Lynch syndrome, but these were included in this calculation as upper endoscopy would detect these cancers as well. The reported event rates and inferred number needed to screen in this meta-analysis appear in line with previous data justifying screening programs to reduce cancer-related morbidity and mortality. Our study found a pooled incidence rate of gastric cancer of 1.1% and 1.4% for duodenal cancers. The reported follow-up periods of included studies range from a single endoscopy to a calculated average follow-up of 8.7 years, which is relatively short and suggests that the actual detection rates of gastric and duodenal cancer may be higher with longer follow-up periods. An area of uncertainty in the implementation of upper GI screening in persons with Lynch syndrome is whether or not to target those with higher risk genes based on pathogenic variant. Our study found a pooled incidence rate of gastric and duodenal cancer in 0.9 and 1.4% of MLH1, 1.5 and 1.6% of MSH2 and EpCAM, 1.2 and 1.3% of MSH6, and 1.1 and 1.3% of PMS2, respectively. When subgroup analysis was done based on gene subtype, there was no difference between Lynch syndrome-associated gene and gastric or duodenal cancer detection. Multiple reports have discussed that H. pylori eradication therapy reduces the incidence of and mortality of sporadic gastric cancers. In this meta-analysis of Lynch syndrome patients, there was a pooled incidence rate of 9.9% for H. pylori. This is lower than the reported prevalence of H. pylori infection ranging from 18.9 to 87.7% in varying regions around the globe. There are several possibilities for why the rate found in this study might be lower than expected. These include prior treatment and eradication, including via non-endoscopic methods that were not be reported in the included studies, decreased detection due to variations in biopsy patterns, and lack of demographic risk factors for H. pylori infection in the cohorts of included studies, which primarily report on cohorts from Europe and the US. In conclusion, this meta-analysis demonstrates the utility of endoscopy in the evaluation and detection of Lynch syndrome-associated upper GI cancers in persons with Lynch syndrome. Future studies should evaluate the mortality benefit and the cost-effectiveness of such programmatic screening. The results of this study support endoscopic evaluation across all genes with a pathogenic variant as part of a comprehensive cancer risk management program for persons with Lynch syndrome. Again, thank you for your time and interest in our manuscript.